Good morning, everyone. Uh, I am going to present my thesis data presentation here on today. My thesis was fecal microbiota transplant for alcohol use disorder in patients with cirrhosis. It was a randomized control trial under the guidance of Dr. Vinod Arora sir. My co-guides were as follows. My CTRI number and NCT is as mentioned. First of all, background and literature review. As we all know, alcohol-associated liver disease is the leading cause of morbidity and mortality. Approximately 0.9% of all global deaths and 50% of all liver cirrhosis are attributable deaths. This is the ILBS data till 2023. As we can see, almost 42% of all the patients visiting ILBS were diagnosed with having alcohol-associated liver disease. Alcohol de-addiction, since 42% of liver disease patients were alcoholics, we can say that alcohol de-addictions plays a major role in management of these patients, which affects in reduced mortality, less need of liver transplant, recompensation, less liver decompensations, fewer hospitalization and reduced costs, and improved quality of life and mental stability. So, as you all know, peri and post-transplant phases pose some challenges for these patients with chronic alcohol use, such as nutrition deficiency, malnutrition, and sarcopenia. That is why early treatment of alcohol use disorder can reduce craving and delay transplant needs. Existing drugs show partial response till now, and they all are mainly neuromodularatory. And only three approved agents till now for alcohol use disorder: acamprosate, disulfiram, and naltrexone, out of which only baclofen has proven safety in cirrhosis till now. This translates to urgent need for safer and more effective therapies. When we talk about normal microbiota, what constitutes a normal microbiota? Almost 97% of human gut is consistent of these two species of microbiota in human gut, and its function are to maintain the regulation of bile acids, the short chain fatty acid metabolization, colonization resistance, and antimicrobial peptide productions. The study done by Adolarato G at in Liver International in 2020, they studied the microbiota changes in AUD patients. They suggested that a few bacterial species such as Colensella and Prevotella were alcohol metabolizing, and they overgrew in patients with having chronic alcohol use. Whereas Akkermansia named bacterial species which was associated with mucus production and gut barrier were impaired, and this translate to increased inflammation. Although also Bifidobacterium and Ruminococcus, loss of beneficial anaerobes and SCFA producers were also seen in AUD patients. On the other hand, oral microbiota the increase in oral microbiota was seen in full frequency of these patients with AUD. These are the species which showed an increase in AUD patients, and this green bar showed a decrease in AUD patients. Till now, there is only one trial in which FMT has been used in alcohol use disorder treatment. This trial was published in 2020 in Hepatology by Dr. Jasmohan Bajaj sir, which was a phase 1 double-blind randomized placebo-controlled trial. In one arm, they gave FMT enema, which was a retention enema, and the other arm, they used placebo enema, which was also a retention enema. 20 patients were taken, 10 in each group. The average MELD was 8.9, plus minus standard deviation of 2.7, and they followed the patients. It was basically a phase 1 trial for safety of FMT. They also look into the alcohol craving questionnaire. At 15 days, they looked into the difference in both the craving and abstinence. Craving reduced by 90% in FMT group versus 30% in placebo group at day 15. They also measured objective assessment of alcohol use disorder by measuring urine ethyl glucuronide by creatinine ratio, which was also significantly reduced in patients receiving FMT enema. So the past, as mentioned earlier, the past studies have the few changes were observed in the past studies when given FMT in alcohol use disorder patients. These all are the mentioned bacterial species which showed decrease and which were associated with decreased alcohol intake and reduced craving. So with that, lacuna in literature was that currently only baclofen is tested and safety and efficacy in patients with cirrhosis out of the three FDA approved drugs for AUD. FMT, although found to be effective, but only a single study available so far for alcohol use disorder. Our concerns were that it was not tested in Indian patients for AUD. The route was still not established, and the number of sessions were not established. So our hypothesis was FMT is useful in reducing craving and return to heavy alcohol drinking in alcohol-related cirrhosis patients with continuous alcohol intake through modulation of gut microbiota and correction of dysbiosis. Our aim was to assess the efficacy and safety of FMT in decreasing relapses, and maintaining alcohol abstinence in AUD in patients with cirrhosis. This was an open label parallel group randomized controlled study conducted in ILBS New Delhi, mainly consistent of outpatient clinic, alcoholic cirrhosis attending outpatient clinic. All consecutive patients with alcohol-related cirrhosis with serum bilirubin of less than 5 with continuous alcohol usage aged between 18 to 80 years were taken as inclusion criteria. They all were fulfilling DSM-5 criteria for alcohol use disorder, which was defined as per the DSM-5 definition given in 2013. Exclusion criteria were as follows: any serum bilirubin of more than 5, grade 2 or more ascites, any episode of HE grade 2 or more or requiring hospital admission within 3 months, episode of bleed within last 3 months, treatment with corticosteroids or immunosuppression within the past 60 days, unwilling to participate, depending on any other substances except nicotine, etc. So trial intervention therapy was given by upper GI gastroduodenoscopy approach. In group one, there were two groups. In group one, the therapy was fecal microbiota transplantation along with standard medical care. Standard medical treatment consists of baclofen, oral medication for reducing the craving, plus AUD counseling done by the psychiatry department. Group two consists of standard arm where only baclofen was given along with AUD counseling and no fecal microbiota transplantation was given. This was the study design. There were two arms, as you can see, FMT plus SMT arms and standard arm. And we followed up the patient till 6 months with three timelines. Baclofen, we started with a minimum dose of 15 milligram per day. We tried to titrate the dose of 30 milligram per day. And microbiota and mucosal composition was seen in FMT group at baseline and 3 months. So our primary outcome was to assess proportion of patients achieving and maintaining alcohol abstinence at 4 weeks or 1 month, and along with that, safety of FMT in these patient group. Our secondary outcomes were to see changes in microbiota and mucosal composition and diversity at 3 months, to assess proportion of patients who got FMT at 3 months without liver-related adverse events compared to placebo or standard arm, to maintain proportion of patients maintaining abstinence from alcohol at 3 and 6 months, to assess difference in craving measures between groups at 1, 3, and 6 months, and to assess the proportion of patients developing lapses and relapses at 1, 3, and 6 months. Our sample size were estimated according to the study given by Jasmohan Bajaj sir in 2020. So we assumed that abstinence rate in the standard group was 50% and anticipating a 40% absolute increase in the FMT group, which translated to 90%. So with an alpha error of 0.05 and a power of 80%, total of 48 cases were initially planned. Considering a potential 10% dropout, it was decided to enroll 27 patients in each arm with a total of 54 patients for this study. Sequence generation was done by an independent person and the randomization was done by IWRS system. Patient evaluation tools. Patient was evaluated on the basis of self-reported history of use, which was always corroborated by a family member. Diagnosis of AUD by DSM-5 audit scale and OCDS scale. OCDS is obsessive compulsive drinking scale used for craving, and 5-point Likert scale. Alcohol quantity frequency semi-structured questionnaire like number of drinking days or lapses in the past 1 month, grams of alcohol in one typical day, etc. was taken. There were 4 follow-up schedules: baseline, 1 month, 3 months, and 6 months. So basically, every time the patient visits here, one session of brief intervention according to WHO standard protocol was taken, and a candidate and trained nurse under the supervision of Dr. Mohit Vashne sir. Assessment of abstinence. Patient's self-evaluation was used as assessment of abstinence. Serum ethynyl glucuronide level was initially planned as a measure of objective assessment, but it was no longer available when we started the study. Family member interview was also done along with the patient's self-evaluation. This is the donor evaluation when we went for FMT. These are the tests which we performed for donor evaluation when we look for FMT donors. This was the exclusion criteria for donors. And technique of FMT was that healthy donors were screened as per the LBS FMT proforma. Stool collection was done. Stool sample from healthy donors was processed in Department of Microbiology. I would like to extend my thanks to Department of Microbiology for their unconditional support for this thesis. Patient preparation was done at least 2 weeks of total antibiotic abstinence, including rifaximin, which can be started after 2 weeks of FMT. If on lactulose, it was stopped 48 hours before procedure. Patient was kept MBO for 4 hours prior to stool installation. The patient was allowed to consume the prescribed diet 2 hours after the procedure or stool installation. Single dose FMT was given via upper GI gastroduodenoscopy beyond D3, D4 junction duodenum, approximately 90 ml in quantity, 30 grams of stool. So stool was given by using upper GI gastroduodenoscopy. We go to D3, D4, and then via an injection catheter, we instill the FMT via syringe to the distal duodenum and proximal jejunal part. Reporting of adverse events. Adverse events were reported as per the common terminology criteria for adverse events criteria, and they were classified as none, remote, possible, and probable. Serious adverse events were defined as hospitalization or emergency room visits during the study. Specific adverse event that we reported was as follows. Stopping rule for baclofen, since it was a single dose FMT, there was no stopping rule for FMT, only for baclofen. If the AST or ALT is 3 times upper limit of baseline, withdrawal of consent, new onset decompensation, worsening of bilirubin more than 5, sedation or worsening of hepatic encephalopathy. So I come to my analysis. So we screened a total of 237 patients. We excluded these patients, and after exclusion, we randomized 54 patients, 27 patients in the FMT arm and the 27 patients in standard arm, and then we followed these patients up to 6 months. Right now, all patients completed their 3 months of follow-up. Only 50 patients have achieved the 6 months of follow-up. So I will be presenting data as per. So baseline characteristics between both arms, they were comparable. Age was mean age was 43.3 with plus minus standard deviation of 8.5. All the patients were male, so I have not mentioned the gender, the other 100% males. And as you can see, total bilirubin and INR also were comparable in both these groups at baseline, along with GGT and ALT levels. Serum MELD score were also comparable at baseline, which was a median of 11.9 plus minus 4 standard deviation in FMT and 12.7 plus minus standard deviation of 4.2, with no significant difference in baseline values of these. These were the alcohol characteristics with the weekly alcohol in grams and duration of alcohol intake in years as mentioned, which was non-significant in both the groups. Time from last intake to therapy is written in median with range. It was with a median of 13 days from last intake to the therapy given. Smoking was associated with 52% in total cohort, with 55.6% in FMT arm, and in the standard arm it was 48%, which was also non-significant at baseline. As you can see, almost 90% of patients in both the arms, more than 90% of patients were either moderate or severe alcohol use disorder graded according to the DSM-5 criteria. And the number of binge episodes were also high in both the groups and the total cohort. So these were the baseline alcohol scores which was used. Obsessive compulsive drinking scale, which was further divided into obsessive component and compulsive component, and the audit scale, which was the WHO scale for calculating the alcohol use disorder in both these groups, which were also comparable. Baclofen dosage, per day of baclofen dosage, we were able to achieve a mean dose of 25 milligram and approximately 25 milligram in both the groups, with a standard deviation of approximately 5 to 6 in both the groups, which was non-significant. Outcomes. So our primary outcome was the proportion of patients maintaining abstinence. So at 1 month, although numerically there was advantage in the FMT arm with 52% of patients maintaining abstinence out of 27, but the p-value was non-significant. But at 3 months, there was a significant difference, with standard arm almost declining to 0. And on 6 months also, although the patients which have completed the follow-up is only 50, but only 2 patients in the FMT arm has been able to maintain abstinence. Uh, we were only giving one baseline doses of FMT in both in the FMT arm. The FMT was not repeated in these patients. So these are the lapse and relapses. Relapses were defined as mild, moderate, and severe relapses according to the number of drinks that a person consumes. And if a person doesn't fit in the three definitions, it will be counted as lapses. As we can see, at 1 month, there was no difference in relapses in between the both arms, but in third month, when we followed up, the number of mild and moderate relapses were significantly better with in the FMT arm. And also at 6 months, the number of moderate relapses were significantly better, significantly more in standard arm. Almost all the patients have moderate relapses, one or more moderate relapses. In this relapse and relapses, single patients is counted in multiple groups because a single patient can have episodes of lapse, severe relapse, moderate relapse, and mild relapse in the preceding follow-up period. Adverse event for immediate reported following FMT and standard arm. So these were within 7 days of administrating the FMT. As we can see, when both arms were compared, uh, these were the adverse events that were reported in FMT arm. Although numerically, FMT arm has a little bit more adverse events following FMT administration, but they were statistic. There was no difference. The p-value was same in both these arms. Liver-related clinical events in FMT and standard arm at 3 months. So these are the liver-related clinical events. As you can see, uh, both were comparable. There was no difference, and all these patients, the three patients in FMT arm, and approximately more than that in a standard arm, were all of them were having relapses, and all of them were treatment failure, which showed liver-related clinical events. So this can be attributed to the continuous alcohol consumption related advancement of liver disease. Stool microbiota composition, we have given the paired stool samples in our NGS lab. So stool microgenome metagenomics is still under process, and we will be getting results as soon as next week. So there are a few longitudinal changes in alcohol craving in patients. So they were the longitudinal changes, and we can see the OCDS score along with that the obsessive component and its compulsive component. As we can see, there was a significant difference at 6 months and at 3 months when we compare both the groups of FMT and the standard group. As we can see at the baseline, they were comparable, but the statistically significant difference were seen at 6 months and over the period of follow-up in both these arms. That translates that FMT, maybe although only 6 patients in FMT group were able to achieve abstinence, but FMT does have an effect on obsessive and compulsive thoughts of AUD patients. Also, the same with audit score, which also showed a significant difference in both the arms as we go with the follow-up. They were the number of drinks in a week and number of drinks in a month, which were also calculated in both the arms, which also showed significant difference in both the arms of FMT and standard arm, with p-value achieving significance past 1 month. So as understood, the MELD score and MELD sodium score also showed significant difference in both the arms with a baseline comparable. And then as we go along the study, there was a significant difference in both the arms in when FMT was compared to the standard arm. So our conclusion is that this prospective randomized control trial is the first one to evaluate FMT in patients with alcohol use disorder and cirrhosis in an Indian scenario. Primary endpoint showed a favorable but non-significant trend towards benefit with FMT. Significant improvements were observed at 3 months, with more FMT recipients maintaining abstinence compared to placebo or standard arm. Relapse severity was substantially lower in the FMT arm, fewer moderate relapses at 3 and 6 months when compared with standard arm. These effects were seen despite both groups receiving standard medical and psychological therapy, supporting a probable microbiota specific mechanism of action. FMT was safe and well tolerated with no infectious or serious adverse events reported in that group. Rates of hepatic encephalopathy and ascites worsening was similar in between the groups. The findings suggest that FMT can safely reduce relapse severity and support abstinence in AUD in patients with alcohol associated cirrhosis. My limitations were that it was a small sample size of 27 in each group. Only single dose FMT regimen was given. It was a single center design, and uh, self-reported alcohol use was used. Path levels came later when we started our study, so no objective measurement was done in all the patients. And a future directive can be this can lead to larger and multicentric RCTs to confirm efficacy and assess long-term benefits of FMT on abstinence. We can also optimize FMT protocol. Maybe since we achieve significant difference in between both the arms at 3 months, so we can repeat dosing of FMT at 3 months. And also we can use alternative routes like in West we use oral capsule, or we can use FMT enema, etc. And donor selection criteria to maximize microbial engraftment and clinical benefits. And we can also use objective measurements of alcohol abstinence in future studies such as PEth levels, which is now available in our institute. Thank you.
Dr. Surjit, very nice thesis, but since both the arms were comparable in the sense of AUT counseling was done in both, in this thesis, have you evaluated the impact of aversive behavior of this uh, fecal microbiota transplant and endoscopic procedure on the outcomes?
Sir,
There is a aversion behavior if some patient is undergoing FMT and plus endoscopic procedure versus the standard arm.
sir, endoscopy procedure was done in both arms. Endoscopy was performed in both arms
Okay.
as a routine measure for screening and all purposes. If the person is on endotherapy, then he will go to endoscopy. But only FMT was instilled in one group. So
Okay.
endoscopy was done in both arms, but we
On
haven't
the
given
all occasions.
on not endoscopy was done twice in FMT arm, but only once in the standard arm.
There should have been a placebo arm also.
So placebo arm.
Thanks.
I have a question.
No.
So where the most of 80% of the alcohol, where it's absorbed,
Uh,
most of the alcohol.
Proximal jejunum or the small intestine.
Yeah. So if you do where the most of the bacteria live, in the lower part of the intestine, right? So by doing a microbiota transplantation, how you think this is working? That is one question. And my second question is that the number of variables you are dealing with is enormous compared to the number of subjects you have studied. So how can this study be valid that way? And and third question is that the patients may have a psychological, the improvement which you might have seen may be just psychological, because you are subjecting certain number of patients for a procedure which is bit invasive compared to the placebo. That itself make those patients who are treated more cautious or prevent them from drinking alcohol, a behavioral change.
Sir, responding to your first question, the FMT do works according to the past studies. For that confirmation, I would like to wait for my stool metagenomics to come, and if that also shows significance to and that also shows correlation with our results of maintaining abstinence and the subgroup analysis of patients maintaining abstinence and the microbiota changes, then I can answer your questions.
Shrijit, a very good study. And you did all the FMTs yourself in all your patients?
Some certain.
Okay. So, and did you do the entire questioning? Because that is a part of your study and you should have done
Yes,
it.
ma'am. Yes, ma'am. OCDS
Just
and
one thing to ask. And the important thing is, when we designed, I know we should not be questioning the design of the study, but why primary endpoint is at 1 month? Because the process of the entire thing will at least take the FMT screening. So what was the time when the patients were randomized and to the time to the primary endpoint? It must be 15 days or so. procedure and the endpoint. So that is why the primary endpoint most likely was not rightly, because you look at 6 months as the primary endpoint. And again, I'm surprised that 3 months is significant, but 6 months is not. So why is it so?
Ma'am, likely the stool has its, the FMT is showing its effect up to the 3 months only, and then it vanished. This study shows this only, that after 3 months, we need to be having repeated dosing of FMT, most probably, by this results. We are, the results we are getting.
Patients are coming and it's an open label study. So somebody who's going back to drinking, the counseling, what are the drugs of means, because standard medical treatment is something which has not been properly defined in your study protocol. And if the patients on FMT arm went back, then what was the protocol? They were just managed like that.
They were just managed at.
So that standard medical treatment should have been properly designed. Means we should have a protocol here. How was these patients managed?
Okay, final comment from Dr. Vinod.
So from our study, basically concluded that FMT is safe, effective in likely maintaining a short-term abstinence up to 3 months. But beyond 3 months, the effects are comparable between the placebo and the FMT arms. So maybe repeat dosing or a longer period of trial duration may help in identifying the exact dosing and the of the FMT. Sir.
If there are no more questions, thank you, Sarjeet. We have the next presentation.
Thank you, sir.
Good morning, everyone. Respected faculty. I'm Dr. Velar Gautam from the Department of HPV Surgery. Today, I'm going to be discussing my thesis, which is correlation between persistent post-liver transplantation ascites and lymphatic molecular dysfunction, a pilot study. My supervisor is Professor Dr. Vinendra Pamechan. These are my co-supervisors. This is going to be the outline of today's discussion. Coming to the background, ascites represents the most common manifestation of decompensated cirrhosis. About 5 to 10% of the patients with compensated cirrhosis developing ascites annually. Liver transplant is the best treatment option for patients with decompensated cirrhosis and ascites, as it induces resolution of ascites by reversing hemodynamic derangements and functional renal impairment. However, small to moderate ascites after liver transplantation is frequent in the early postoperative period, and it usually resolves within 2 to 4 weeks of transplant. And despite the ascites being post-transplant ascites being rare, it is associated with worse clinical outcomes, including higher morbidity and reduced 1-year survival. And coming to the lymphatic dysfunction in chronic liver disease, this is a study published in Cellular and Molecular Gastroenterology and Hepatology, where they have studied patients with chronic liver disease. And this was a depiction of an example patient where NASH was taken. In NASH, there is increased inflammation as well as increased oxidized LDL, which is a product of paroxysmal, and it causes the loss of lymphatic identity as well as the junctional integrity of the lymphatic endothelial cells, which leads to impaired lymphatic drainage. This was the biopsy of the NASH was taken from the liver biopsy was done in the NASH patients at various stages, and they have used animal model of mice with NASH model. Coming to the etiological factors of post-transplant persistent ascites, coming to the recipient factors, that is recipient's age, primary disease, MELD score, Child-Pugh score, high volume of ascites at the time of transplant, and renal impairment. Coming to the donor factors, the portal vein graft diameter, hepatic venous graft diameter, graft volume, and high donor age contribute to persistent ascites. And in the intraoperative parameters, left lobe graft, more operative time, GRWR, portal hyperperfusion. Persistent ascites is more common in living donor liver transplant as compared to dead donor liver transplant, and high blood loss intraoperatively. And longer anaphylactic phase and longer pearl ischemia time contribute to persistent post-transplant ascites. Coming to the post-operative parameters, hepatic venous stenosis, venous outflow obstruction, graft rejection, portal vein thrombosis, and high post-transplant portal venous pressure these are the most important etiological factors for post-transplant persistent ascites. Coming to the review of literature, A study published in 2000 by Isabel Sierra. This was a study done in DDLT setting where they have retrospectively analyzed 378 samples where they have taken the definition of persistent ascites as more than 500 ml at POD 10. They have reported that the prevalence of persistent ascites was 7%, and it was associated with increased risk of renal failure, peritoneal infection, prolonged hospital stay, and possibly shortened survival with reduced 1 year survival, 1 year overall survival. Coming to the next study, which was published in 2013. This was also done in DDLT setting, where they have analyzed 585 samples, 585 patients, and they have taken the definition of persistent ascites as ascitic fluid persisting more than 4 weeks, and they reported the prevalence as 5.6%, and they have concluded that the persistent ascites after liver transplant is associated with reduced 1 year survival, and the important risk factors for the persistent ascites were pre-transplant refractory ascites and retransplantation. And in the multivariate analysis, they found that intra-abdominal infection, venous outflow obstruction, and renal dysfunction to be the contributory factors for persistent ascites. This was another study published in 2014. This was done in the setting of LDLT, a retrospective study where they have analyzed 105 patients, and they have reported the prevalence as 25.7%. They have defined massive ascites as more than 7 liters of ascites produced during first 7 days after LDLT. After the analysis, they have seen that on multivariate analysis, they have seen that Child-Pugh score, operating time, and right hepatic vein graft diameter were the independent risk factors for massive ascites after LDLT. This was a study published in 2018 in the setting of living donor liver transplant. They have analyzed 439 samples, and they have reported that they have a prevalence of 17% of ascites. They have defined persistent ascites as more than 1 liter of ascitic drainage beyond POD 14. They have seen on multivariate analysis, they have identified 5 significant risk predictors for persistent ascites. They are preoperative serum creatinine more than 1.5 milligram per deciliter, recipient spleen to graft volume more than 1.3, a left lobe graft, and more than 1 liter of ascites at laparotomy, and GRWR of more than 0.8. The clinical scoring system was devised, and they have concluded that persistent ascites reduce long-term survival in the patients. This one another study done in the setting of LDLT, where they have analyzed 413 samples and 413 patients, and they have reported the prevalence of persistent ascites as 48.4%. They have defined persistent ascites as more than 1 liter ascitic drainage on POD 14. They have included the surgical ICD as well as the ascites leak through the wound. They have concluded that recipient age, Child-Pugh score, graft volume, preoperative ascites of more than 500 ml, intraoperative blood loss, and longer anhepatic time to be one of the risk predictors for developing persistent post-transplant ascites. Our center experience, this was a thesis done by one of our seniors. We have studied the prevalence of persistent ascites, and this was done in the setting of LDLT. We have analyzed samples of 655 samples, where we have seen 292 patients having persistent ascites, which is 45%. We have defined persistent ascites as more than 1 liter per day on POD 14, including the pleural effusion and the surgical. On multivariate analysis, high Child-Pugh class, sarcopenia, left lobe graft, significant ascites at the time of liver transplant, LDLT. We have defined significant ascites at the time of liver transplant as more than 5 liters, whereas in the previous study done in 2018, they have defined more than 1 liter ascites at laparotomy as significant ascites. And postoperative sepsis, postoperative high bilirubin levels, and low serum sodium levels on POD 14 were significantly associated with persistent ascites after living donor liver transplant. And these were 2 studies which were published in 2019 and 2021, where they have concluded that liver lymphatic vasculature significantly increases in parallel with the progression of disease and independent of the disease etiology. Coming to the lacunae, there are no human studies that have examined lymphatic microstructure of the hepatic hilum in healthy individuals compared with those with cirrhosis. And there are no studies evaluating the role of lymphatic dysfunction as a cause of persistent ascites post-liver transplant. The hypothesis is that the dysfunctional lymphatics of the liver are an important contributing factor to the development of persistent ascites in the post-liver transplant patients. Our aim is to evaluate the correlation between lymphatic molecular dysfunction and the development of persistent ascites following liver transplant. My objective, sir, the primary objective is to evaluate the correlation between lymphatic molecular dysfunction and development of persistent ascites following liver transplant. The secondary objectives are to compare the levels of lymphangiogenic markers and lymphatic endothelial markers between patients with and without persistent ascites, and to assess the clinical, biochemical, and graft-related risk factors contributing to the persistent ascites. Coming to the methods, the study was a prospective observational pilot study done in our department, and the inclusion criteria were all the patients who underwent LDLT up to July 2025 in the department, and the exclusion criteria were ALF, ACLF, and DDLT in pediatric recipients, as the persistent ascites differ in these groups. Our definition of persistent ascites, the one which we took in this study, was ascitic output more than 1 liter on POD14 after liver transplant. The daily ascitic discharge was assessed as loss of fluid through abdominal drain or chest drain tubes and the surgical veins. Coming to the methodology, during the surgery, the perihilar fibrofatty tissue, lymphatic tissue, and lymph nodes were taken. These were sent for histopathological, immunohistochemistry, and the molecular studies. On the first upper image, you can see this was a lymphatic being taken in the donor side, and these were the lymph nodes being taken from the recipient side. On POD14 of liver transplant, on LDLT, the volume of ascitic fluid, any if present, was recorded, and from this point, the patients were assigned to 2 study groups based on whether the volume of ascites was greater than or less than 1 liter. All clinical information was gathered from the medical records. A lymphatic function was assessed by collagen deposition, immunohistochemistry for podoplanine. Quantitative RT-PCR was done for lymphangiogenic genes and cytokine genes in hepatic lymph nodes as well as the lymphatic vessels. Study design, we have taken all patients undergoing LDLT, and healthy donors was taken as controls to compare the lymph node pathology in both the patients with persistent ascites as well as the without persistent ascites. The appropriate statistical analysis was done. Coming to the results, these were our donor characteristics. The donor lymph nodes which we could procure were all right lobe donors. Mean age of the donors was 35.7, with most of them being female donors, 53.8%. Some of them had comorbidities, but they were controlled and taken up for donor surgery. Comparison of the preoperative demographic and clinical parameters between both the recipients. Most of the recipients were male, with 80% being male. And the etiology, most common etiology was autoimmune hepatitis. Ethanol was 13.3%, and all of them was CLD. And there was no significant difference between both the persistent ascites as well as without persistent ascites. In the preoperative parameters, most of our patients were child B or child C class, with one of them having portal vein thrombosis. Previous ascites was noted in 14 patients, around 93.3%. And SBP was seen in around 5 patients. Sarcopenia was noted in 10 patients in our group, with patients with persistent ascites having 90% of them having sarcopenia, which was found to be significant between both the groups. And continuing on the demographic parameters, mean age of the patients undergoing in this study was 47.7%. The mean MELD sodium score was 22.53, mean MELD3 was 20. And the serum creatinine was found to be significant in preoperative serum creatinine was found to be significant in both the groups, with patients with persistent ascites having higher levels of serum creatinine. Serum alkaline phosphatase was also found to be significant. Comparison of the intraoperative parameters between both recipients with and without ascites at POD14. In our patients, the mean intraoperative ascites was 6.1 liters. And significant ascites, which was defined as more than 5 liters at the time of liver transplant, was found in 46.7% of the patients. And the blood gloss, anaphylactic phase, cold ischemia time, and warm ischemia time were comparable in both arms. The operative time was more in the patients with without persistent ascites. Continuing with the intraoperative parameters, graft weight, GRWR, portal flow, the type of graft, they're all comparable between both the groups. And coming to the postoperative parameters, the POD14 ascites on the mean was 1800 ml. With the patients with significant ascites, the mean ascitic output on POD14 was 2500, approximately 2500 ml per day, and it was found to be significant. The length of patients with persistent ascites had more number of ICU with HDU days, higher incidence of postoperative AKI, higher incidence of postoperative sepsis, and higher major postoperative morbidity, which were significant in both the groups. 90-day mortality was compared in both the groups. Coming to the histopathological analysis of the hepatic lymph node as well as the lymphatics, the picture A and B show a normal donor lymphatic, normal donor lymph node, and the A and B, A is hematoxylin and eosin stain, and B is mesenterichrome staining, showing us the collagen deposition. And D and E belong to these two images belong to the recipients without persistent ascites, where we can see mild increase in fibrosis and vascular expansion with visible lymphoid follicles, consistent with adaptive lymphangiogenesis, which was already proven in the previous studies. And in recipients with persistent ascites, there is marked fibrosis and disrupted architecture with dense collagen deposition. And you can also see regressed lymphatics indicating advanced nodal remodeling and impaired drainage. And on comparison of the collagen positive area between the donor, recipient, healthy donor, recipient without persistent ascites, and recipient with persistent ascites, there was significant difference in the collagen deposition, and we can say that the hepatic lymph node fibrosis was increased and as compared with the donor. Coming to the quantification of podoplanin vessels, this was an immunohistochemistry done. C is the donor lymph node, F and I. F belongs to the recipient without persistent ascites, I belongs to the recipient with persistent ascites. In this image, you can see that in the recipient without persistent ascites, there are increased number of dilated podoplanin positive lymphatic vessels, as well as increase in the number. In comparison to recipient with persistent ascites, we can see only few podoplanin lymphatic vessels, as well as the diameter of the decreased diameter of the podoplanin positive lymphatic vessels. When we compare this, there was significant difference in the donor and compared to recipients in terms of number of podoplanin vessels as well as the diameter of the podoplanin lymphatic vessels. And in recipients with persistent ascites, podoplanin positive lymphatic vessels were sparse and completely regressed, which you can see in this image labeled I. Coming to the gene expression markers, we have done RT-PCR of gene expression markers of podoplanin, L/VE1, FLT4, VEGFC, and VEGFD. And the gene expression data indicated a reduced expression of common lymphatic markers in both the recipient groups as compared to the donor, and the expression of some genes were still further reduced in recipients with persistent ascites. Coming to the gene expression data of pro-inflammatory as well as the anti-inflammatory cytokines, the pro-inflammatory cytokines of CXCL1 and TNF-alpha, both were reduced in the recipient group as compared to the donor, and the anti-inflammatory cytokines were also reduced in the recipients. And the reduction of the pro-inflammatory and anti-inflammatory markers were reduced in both recipient groups, indicating compromised immune response. Coming to the summary of my findings, persistent ascites after liver transplant is a common postoperative complication occurring in substantial proportion of recipients despite adequate graft volumes and operative success. Mild predominance in NASH cirrhosis were leading demographic etiological patterns, and the high MELD and CTP score, along with pre-existing ascites and renal dysfunction, were strongly associated with the development of postoperative ascites. Sarcopenia emerged as a significant predictor of persistent ascites, and the intraoperative variables such as longer operative duration, higher ascitic volume, and portocaval shunt time correlated with persistent ascites severity. The histopathology demonstrated collagen deposition in recipients with persistent ascites, confirming ongoing fibrogenic remodeling linked to impaired lymphatic drainage. And on the podoplanine immunohistochemistry, which revealed decreased lymphatic vessel density and caliber in patients with persistent ascites, indicating attenuated lymphangiogenesis and reduced drainage capacity. And there were downregulation of lymphangiogenic markers and suppressed cytokine gene expression, confirming molecular evidence of lymphatic endothelial dysfunction and immune quiescence. The integrated analysis supports that lymphatic dysfunction, impaired angiogenic signaling, and metabolic frailty collectively underlie persistent postoperative ascites following liver transplant. Comparison with the literature, the reported incidence ranges from 5 to 25%, and the Ito et al. And Lee et al. Highlighted preoperative ascites, renal dysfunction, and intraoperative factors are major predictors. And Musenik et al. Demonstrated correlation between pre-LT serum creatinine and pre-existing ascites and postoperative fluid retention as important major predictors for post-transplant ascites. Our study findings are consistent with global trends showing hemodynamic and lymphatic interplay influencing postoperative outcome. And the significant impact of preoperative ascites and renal dysfunction was seen. Ito et al. Emphasized that anaphylactic phase and intraoperative hemodynamics as independent predictors paralleling our findings. And the incidence of persistent ascites in our study was 66.7%, higher than Lee et al. And Ito et al. And the histopathological evidence of increased collagen reduced podoplanine lymphatic vessels, aligning with Jeong et al. And Tanaka et al., which are published in normal liver biopsies. Downregulation of lymphangiogenic markers in our study supports earlier experimental findings of impaired lymphatic regeneration and the cytokine suppression, as well as it parallels the immune dysregulation model. Coming to the conclusion, persistent ascites after liver LDLT is a multifactorial condition driven by pre-transplant, intraoperative, as well as the postoperative parameters, postoperative factors. In the histopathology of our study, there is increased collagen deposition, which shows fibrotic remodeling, and there is decreased lymphatic vessel density and caliber on podoplanine staining, indicating structural lymphatic impairment, and the molecular findings, which are already discussed. The thing unique to our study is that the molecular and histological demonstration of lymphatic insufficiency. And while prior studies emphasized hemodynamic causes, our data highlight lymphatic remodeling as an additional mechanistic factor. And coming to the limitations of the study, the sample size was small, around 15 samples were taken. Histopathological and molecular analysis were limited to available tissue samples, precluding serial evaluation of temporal lymphatic changes. The impact of immunosuppressive regimens on donor characteristics on lymphatic recovery was not evaluated. The potential confounders such as preoperative infection, nutritional support, and hemodynamic variability would influence ascitic outcomes and biochemical markers. Thank you. And I would like to acknowledge the Dr. Savneet and her team, Dr. Ms. Aarti, for their support for the histological analysis of this lymph nodes. Thank you.
Thank you. Quite an innovative study. Any questions? Yes.
Ascites and cirrhosis versus post-operative ascites, because I believe the mechanisms are very different. Can we just compare the mechanisms?
In the preoperative setting, it is mostly due to splanchnic vasodilatation, sodium and water retention, and due to in the postoperative, it is due to multiple factors are at play. They include the recipient factors as well as
absolutely.
Yes, sir.
That is where they think. So which lymph nodes you collected?
The hilar lymph nodes. So
now you tell me. So here, if you are taking hilar lymph nodes, in the post-operative situation, the liver is regenerating. Correct.
Yes.
That will have an enormous impact, because liver itself has a lot of lymphatic drainage, and when the liver is regenerating, lymphangiocytes are also proliferating. So definitely you will find a difference when you are collecting the hilar lymph nodes. That is one point. And second thing is that infections and many of the intraoperative things will have a major impact on all these markers you studied.
Yes.
And that itself, is a major problem. So that's a huge confounding fact. here. That itself can justify all the difference which you have seen.
Okay, Sanal, so do you want to answer him?
Sir, we have seen that there was significant structural difference in both the groups. We have studied multiple samples, for around 10 samples in patients with persistent ascites and 5 without ascites. And there was significant difference in the structural change in both the groups. The functional change will have to see.
So first of all, well done. I think the sample still we need to get more samples into this. And I really want to thank Samneet and team for doing this for us. This is first human work. This has not been done previously. Whatever has been done, I think maybe a bit in animals have been done, but this is first human work where lymphatics and lymph node has been looked into in cirrhotic patient and compared with a normal healthy one. So that was the first part of the story, that we compared it with a normal healthy lymph node and lymphatics with a cirrhotic patient. And obviously we wanted to, because one of the major point is, portal hypertension is supposed to resolve after liver transplantation. But then certain group of patients continue to produce ascites even when the portal hypertension is resolved after liver transplantation. So is there any other mechanism which are into the play? That was the thought process of doing this. And one of the mechanism is failure of lymphatics to regenerate or remodulate after transplantation so that they continue to produce ascites even after transplantation. So that is what we wanted to look into this study. And that's what I think, there can be lots of confounding factors. There will be actually, because there is so much interplay happening here. There is a preoperative factor, then intraoperative, and then obviously a new liver has come in, and immunosuppression, infection, and everything is playing into part. But then this does show clearly that patients who continue to produce ascites actually have failure of lymphatics in those patients. Their lymph nodes they're bad compared to the other ones, and their lymphatics are also bad. So that was the whole idea of doing this.
This is a very good study, I agree, but very innovative, obviously, but the message is like it is a very descriptive. So how do you want to take this knowledge into your clinical practice from your study? What would you propose future?
In the future, ma'am, there are few in the pre-transplant area, in the pre-transplant setting, in normal cirrhotic patients with, for example, NASH, where there was a study where they have shown in mice models that on giving VEGF-C recombinant therapy, there was improved lymph-angiogenesis.
When you had chosen, my just suggestion is like if somebody wants to do like in a very small set of patients, we should have been very selective on the profile of the patients. Like if we would have taken one etiology, maybe refractory ascites patients. So that said, if you're taking a small sample size, otherwise this is just a discovery and this should frame a cohort for a larger study, which should give us a biomarker for finding out where the lymphatics are a problem in patients.
Yeah, I agree. No, and because this is first time we thought about it, and nobody has done this.
This is very good.
So I think we need to be. I think we need to. Maybe we should just take one etiology and see. And this work and our work is different. This is intrahepatic. Liver biopsy.
Liver biopsies.
We are talking about the lymphatics and lymph node in the peritoneal cavity, in the hilar. That's those station lymph node which are supposed to carry the lymphatics from gut and everywhere to the liver. So that's a bit different. So that actually, maybe we should look at the biopsies as well to see what happened within the liver as well along. But I agree, we need to have a homogeneity in terms of patient.
Thank you.